Okay. Um, so this is a project that I've been working on for many years with funding from the CDC for doing modeling to study healthcare infections, so transmissions of bugs in hospitals and long-term care facilities. Um, and the CFA project inspired me to uh, simultaneously turn this into a software tool in conjunction with the manuscript that we're working on that describes the sort of math modeling piece. Um, and I've been using the resources of our the George's excellent software development team as part of the CFA to learn how to create my first R package and turn this into a tool that we hope people can use. For now, it's I think a tool primarily geared towards modelers, but I would love to hear your feedback on whether we can foresee applications of this for um, people who work in public health for healthcare facilities to potentially use this as a practical tool. So the package is called Facility Epimath, and it's geared towards differential equation models for specifically for infectious diseases in healthcare facilities. So the links in the bottom and the footer here are for these slides, which you can view on the web. And then there's the GitHub repository for the R package, and it's actually also just recently up on CRAN. Had a successful submission um, for a sort of first official R package for me. That's up on CRAN, so you can also install it directly from there by uh, just looking for the name Facility Epimath. So here's the motivation. We're interested in healthcare facilities transmission. We know that patients inpatients in hospitals and long-term care facilities transmit bugs to each other while they're there, which is an important problem. Uh, but it's difficult to document the extent to which it occurs and how it occurs. When an inpatient has symptomatic infection onset for something like, for example, an antibiotic-resistant bacteria, it's often unknown whether they brought the organism in with them when they were admitted or whether they acquired it from another patient during that same stay. Because of that uncertainty, the extent to which efforts to decrease transmission between patients, it's hard to predict how much those kind of interventions will actually reduce infections. So this is the problem that healthcare facility epidemiologists are interested in, and the CDC division as well. Another reason that transmission is important is because there may be threshold effects generally documented or quantified by the basic reproduction number R naught being bigger than 1. And it's unclear whether a single particularly high transmission facility could have R naught greater than 1 by itself. If that does happen, then a single facility could sustain or amplify transmission within a community or within a network of facilities by itself. And if that's the case, then an intervention that could reduce R naught less than 1 below the threshold could be highly impactful and cost beneficial. And mathematical models can help address these topics. So that's the motivation for why we're doing this. So what does the package do? So this is our quick description of what it does. It provides functions for simulation-free calculations of useful quantities for a differential equation model of healthcare facility transmission. The two sort of highlight functions that I'll feature today are first calculating the facility basic reproduction number R naught, and second to calculate equilibrium of the differential equation system at a given constant distribution of admission states of the patients. And one of the sort of unique features of this, I think, is to allow both heterogeneous patient states and flexible length of stay distribution for the patients. So by heterogeneous patient states, I mostly mean you could have different compartments or groups of patients that have different susceptibilities to acquiring the organism. And then those who have acquired the organism could have different transmissibilities or um, infectiousness to other people, which could be because of something about their underlying biology or because of an intervention where some patients are put under special contact precautions, for instance, to prevent them from transmitting. And then for the length of stay stuff, we have a pretty flexible system where you could have a state-dependent discharge or death rate. Or you can have a time of stay dependent discharge or a death hazard function, which basically allows you to use any kind of length of stay distribution that you want to match what the distribution looks like in a real facility, for example. So here is a general version of the model with two colonized and two susceptible compartments. The model can actually handle any number of compartments, but I just put two here just to show what it looks like for the 2x2. Colonized are basically the infected person. That's what in healthcare epi, this would be like a SI model where I is usually infectious, but in healthcare epi we call infected people colonized. Um, and I won't go through every parameter in here, but I just want to highlight a couple. First is the acquisition rate alpha, which appears in every equation. That's the rate at which a susceptible patient acquires colonization. And it depends on the number of colonized people still who are co-located in the facility, where the two colonized groups, C1 and C2, could have different transmission rates or different betas to reflect the transmissibility. So every susceptible patient is potentially exposed to every colonized patient and acquires according to that, which is the transmission component. So that's where the nonlinearity comes in this system. And then finally, for the length of stay stuff, I mentioned the two ways that you can model discharge or death, which are the two ways that someone's stay in the facility can end. State-dependent removal rates are governed by these omega parameters that appear in sort of the diagonal as a removal rate. And then we also have this H of T function, where T is the time of stay. So the hazard of being discharged or dying can depend on how long you've already been there, which allows you to model any kind of length of stay distribution. And I'll show some examples that'll make this a little more clear, so you're not just looking at a mess of equations like you are on this slide. So now I'll describe some of the pieces that go into the R package functions. So this is the way that someone using the R package has to sort of break up the equations that I showed in the last slide into the pieces that the model needs to calculate R naught. So first, there's a matrix because there's two susceptible states. The S matrix is a 2x2 in this case. So these are representing the terms in those equations that are the transitions between or out of the two S states in the absence of any colonized patients in the facility. So there's two S states here. They could transition between each other. If a patient's state can change during their stay to make them more or less susceptible, that could govern that. And then the omega subtraction terms, which are the discharge or death rates. Same things for the two different C states. We have a 2x2 because there's two colonized compartments. So there's the CIJ terms that are transitions back and forth between the two colonized states, which could represent whatever epidemiological transition you want. And then for the colonized compartments, there's two removal rates. There's the omegas, which are removal from the facility entirely. And then these R terms are recovery rates. So someone losing colonization, going back to being susceptible are also ways of being removed from being colonized. So together, those give you sort of a duration of remaining colonized, which is necessary for calculating R naught. Then we have this A matrix, which basically just describes from which S compartment to which C compartment do the patients go when they acquire colonization. It also can represent relative susceptibility by the sum of if the sum of the columns are different. Then we have this beta vector, which are the two transmissibility values from the two colonized states. We have the admission state distribution for the susceptible compartments only. Since we're calculating R naught, that means the facility is fully susceptible, and you're calculating the number of transmission expected number of transmissions from that state. So it's a length 2 vector of the that adds to 1 of the admission states for the susceptible compartments. And then we have this function, which I'll talk about more later. It's the moment generating function associated with that H of t discharge hazard function. The distribution for which that is the hazard function, M is the moment generating function of that distribution, which is needed for the R naught calculation. So here's the formula that we derived in manuscript, which is now up on medRxiv and soon to be submitted. I didn't put the link here, but it's called transmission thresholds for healthcare facilities, or something like that. And I won't describe this whole equation, but just want to point out some components. It involves matrix exponentials of those two S and C matrices, which are constant matrices. So those are like solutions of a linear differential equation that involves eigenvalues, eigenvectors. This capital F function is the cumulative distribution function of that function where H of t is the hazard function that are related this way. If we don't have state-dependent removal rates, if you're modeling discharge using only that H of t, then F of t is the CDF of the length of stay distribution. And then the equation involves these integrals that are products of a matrix exponential and 1 minus F of t, which is a survival function of a distribution. And so those integrals can be expressed using the moment generating function of that distribution evaluated at the eigenvalues. And if you have a very simple model where the S and C matrices are small and simple, you can use this formula to generate closed form solutions for R naught, which is what we do a lot in the manuscript. And you can do that when those matrix exponentials can be expressed symbolically. But for most models, other than very simple ones, you can't do that. You need to sort of calculate the eigenvalues and all of these values numerically, and that's what the R package does. So that's all encoded in this facility R naught function that I'll show an example of, and within facilityepimath R package. So here's a relatively simple example. Only one S state, so all patients who are susceptible in the facility are just in the one S state. And we have two colonized states, which represent patients who are not detected as being colonized. So these would be like asymptomatically colonized patients who could still transmit. And then the C sub CD stands for clinically detected. So those would be patients who progress to some kind of symptomatic infection that inspires a clinical test and are identified as being infected with this organism, and put under contact precautions. So the contact precautions are modeled in this alpha equation, which was the acquisition rate. It depends on the current prevalence of patients in both colonized states. Beta is the transmission rate from the undetected patients, and then beta times 1 minus epsilon is the transmission rates from the detected patients, where epsilon is the contact precaution effectiveness. So that would be between 0 and 1. So for a perfect contact precautions, epsilon equals 1, and there's no transmission from the detected patients. We also have gamma, which is the clearance of colonization rate. So going from C back to S. And then this delta C is the progression rate to clinical detection. Um, uh, so transitioning from C to the clinically detected colonized state. So we can represent this system of three differential equations completely for purposes of R naught calculation using these components. These are going to be the input components to the function in the R package. So the S matrix, there's only one S state, so it's a 1 by 1 matrix, or just the one number 0. C is this 2 by 2 matrix. A is the transitions from S to C. So this just means that when someone first becomes colonized, they go directly to C. None of them go directly to clinically detected. So 1, 0. There's only one S state, so only one way to get admitted to the facility. And then we have the two transmissibilities of the two states. So here's how it would look in R using the package. And these values that I'm using here for those parameters are taken from a study that we modeled that was looking at transmission of CRE, which is a carbapenem-resistant Enterobacteriaceae, which is a multi-drug resistant organism, in LTAC, which is a long-term acute care hospital. So we have the clearance rate, contact precaution effectiveness, we assume was 50% effective. And then these beta and delta C values were the transmission rates and the progression rates that were fit to the data from those LTACs, which were LTACs in the Chicago area that were having a very bad outbreak of this organism. So with those values fixed, we can build those components that I showed on the last slide that describe the differential equations. So the S matrix, C matrix, A matrix, the transmission rate vector, and the initial condition. And then this last piece here is defining the length of stay distribution. LTACs have pretty complicated looking length of stay distribution if you look at the distribution of how many days people stay in the facility. So we actually use a pretty complicated distribution, which has 4 parameters. It's a mixture of 2 gamma distributions, specifically a mixture of an exponential and a gamma distribution. And we provide this function here as part of the R package, MGF mixed gamma, that writes down that encodes automatically that moment generating function when you have a mixed gamma distribution with the given set of parameters. So it just takes the probability of following the 2 different distributions in the mixture, the 2 different rate parameters, the 2 different shape parameters, which are sort of the standard gamma, the 2-parameter gamma value parameters. And so you can build that automatically there using that built-in function. And so then we have all the components we need to calculate R naught, the SCA, transmission vector, initial condition, and that MGF, moment generating function. And the R code will spit out the R naught. So one of our conclusions that in the manuscript that we're working on, since you can see the result here was 1.24, which is bigger than the threshold of 1, that is plausible that these LTACs in Chicago were sort of supercritical or above threshold, are not bigger than 1 just for a single stay in the LTAC for this CRE bug, which is a big problem. So the other function, one of the other functions in the R package is calculating the equilibrium. Using this function is very similar to the R naught function. it needs a couple more components. It needs the recovery matrix, which was the gamma rate of recovering from state C to state S. And then the initial condition vector needs to not only be for the S states, but also for the colonized states. So you can calculate the equilibrium if you have a given sort of constant rate of importation of the bug into the facility. So this code here builds on the previous slide and shows we got the extra input component R. And then I built this little function here where you can put in different importation rates for the admitted patients coming into the facility colonized, which builds this init function, which now has three components because we have S and the two C states. And we assumed the importation goes directly to the C state and not to the detected state. And so then you can calculate the equilibrium using this facility EQ function, which is another function in the R package with those input components. It returns length 3 vector of the equilibrium of the three states. So the sum of the second and third state will be the facility prevalence at equilibrium. So what fraction of patients who are inpatients are colonized at equilibrium. And so you can see here if you put in a high importation rate of 20%, so 20% of patients coming in are colonized with CRE, which is about what they were actually observing in those Chicago LTACs. Then the equilibrium prevalence because of transmission is 50%, which is also what they were seeing in the Chicago LTACs. So that kind of relationship there is how we derived the parameters of the model that sort of fit that. And so then you can see how does the facility prevalence change if you reduce the importation rate. You can see here we reduced it to 10%, 1%, all the way down to 1 in 1,000. And you can see even if only 1 in 1,000 admitted patients are colonized, your equilibrium facility presence is still very high at about 20%. That's a consequence of R naught being greater than 1. Because people who acquire in the facility transmit to more than one other patient on average before they get discharged. You basically only need one importation to set off a continual chain of transmissions in the facility. And so even very rare importations can have a lot of infection happening in your facility because R naught is bigger than 1. So that's obviously a problem. So then what to do about it if you have this problem? Intervention. So one way to do that is to find more of the colonized patients and detect them before they become symptomatic and put them under isolation if you can. So that's what this model does. Now we have 2 susceptible states and 3 colonized states. The extra colonized state is now C sub SD, which is surveillance detection. And we have this delta S parameter, which is representing how often do you test patients to see if they're carrying this organism. And then we have another component of the intervention, which is this gamma D. Gamma, remember, is the recovery rate, so going from C back to S. So this part is modeling active sort of decolonization. So if you detect someone who's colonized, can you give them a drug to speed up their clearance rate and decolonize them? So there's actually 2 components of this intervention: seek, contact precautions, and decolonizing. And so we can model that here. We've got the 2 extra values here. I just put in 2 examples here. Surveillance detection rate per day of 1/28, so average only once every 4 weeks. And then a clearance rate of 1/10, which would be an average decolonization rate of 10 days, which is a lot faster than the natural rate. Patients can naturally carry these organisms for like a year or even longer. So here's the components again. We have, and they're written here in sort of R code form and down here in math matrix form. We have two susceptible states now, so 2 by 2 of zeros. We don't assume any transmission transition back and forth. 3 by 3 for the three colonized states. The A matrix is now 2 by 2 because we have two susceptible and three colonized. With this extra susceptible state, we modeled because someone who gets decolonized would still be under contact precautions, which may help protect them from reacquiring by that same rate of epsilon. So that's why that appears there. Um, the admission states for S, we're assuming no, in this version, we're assuming no detection at admission. So everyone comes in undetected, susceptible. And then three transmission rates, where now we have two compartments that are under contact precautions, represented by this epsilon. And then you can see the calculation here. This is actually running the R code within this slide here using a Corto, which is pretty fun. Another thing I learned in the software team. And you can see the output of this R code now. The R naught has jumped below 1. So the intervention pushed R naught from 1.25 down to 0.8, which is very impactful, getting it below the threshold. And you can see it only required surveillance on average once every 4 weeks in the facility because of this decolonization rate. If you didn't have the decolonizing drug, you got to do surveillance a lot more often than once every 4 weeks to get R naught below 1, which is another sort of conclusion from our manuscript. Another possible intervention is to reduce length of stay, because that's a component of R naught. It's right. It's how many people you transmit to depends on sort of that transmission rate, and then also how long are you in the facility. And because this facility that we modeled in the examples is a LTAC, long-term acute care hospital, length of stay is very long, which is part of why they're at such high risk for bad outbreaks of these bugs. So another intervention would be to reduce that length of stay, potentially reduce R naught. But because we have a pretty complicated length of stay distribution, there's more than one parameter that you could modify that would reduce the average length of stay. So specifically, what we modeled here was this mixture distribution. The specific distribution that fit pretty well to the LTAC data of length of stay was this exponential gamma mixture, where we have pretty close to 50-50 mixture of patients following each one. The exponential distribution, by definition, has the same mean as its standard deviation. The mean is a little bit higher than the other one of 35 days. And the gamma distribution has a mean of 32 days and a standard deviation much lower. So that part of the distribution is representing the kind of more peaked shape where you have some patients who are sort of have a more predictable length of stay with a lower variance than you would expect if you just used the basic exponential distribution for everyone. So the mean length of stay overall, combining those two, is about 34 days. An LTAC, by definition, sort of has to have greater than 25-day length of stay in order to be defined as an LTAC for insurance purposes. So they, in this facilities, did have some room to play with. They could get their patients out faster, perhaps with some effort. So one question is, does it matter for reducing R naught, which of these groups are targeted for length of stay reduction? So we sort of tried 4 different methods here of reducing the mean length of stay. There's 4 different parameters of the distribution, and 2 of them are sort of rate parameters, or the average discharge rate So method one would be just to increase the discharge rate of all patients, just kind of speed up the rate of getting patients through their treatments and out. Method two and three would be just to increase the discharge rate of either one, but not the other, the high variance patients or the low variance patients, to the extent that you can predict which patients follow that. And then method four would be to decrease the fraction of high variance patients, which is this PX parameter. So just decrease this 58-42 mixture to have fewer of the high variance patients who could potentially have a very long or short length of stay. And then this shows the code of how you redefine the MGF component of the distribution, which is the same code that we showed before, but just showing again that these four parameters fit into the mixed gamma distribution like this. So you just have to recall that this MGF function and put it into the R naught calculation and see how it comes out. So we got some real interesting results from this. So this is showing the four different methods that I showed, and then it's showing how it decreases the facility R naught. On the left is sort of the status quo, where the mean length of stay was 34 days and the R naught was about 1.25. If you increase the discharge rate of all patients, this is showing how decreasing the mean length of stay down to closer to that 25 threshold. Where do you cross the R naught equals 1? If you increase the discharge rate of all patients, you got to get the mean length of stay down to about 26 days to push the R naught below threshold. But interestingly, if you do that only for the high variance or the low variance patients, so you get a very different result. If you increase the discharge rate of the high variance patients, then you cross the threshold with only a mean length of stay of 28 days instead of 26. And interestingly, if you increase the discharge rate of the low variance patients only, you get the mean length of stay of all patients down potentially to 26, but R naught doesn't go down, and it may even increase, which was kind of surprising. And finally, if you decrease the fraction of high variance patients, and this gives a clue about why this happened, you can reduce R naught very quickly. If you don't have those high variance patients and you only have the low variance patients following a pretty predictable mean length of stay, then R naught decreases quite quickly. You can actually get R naught below 1 with a mean length of stay of still pretty high of over 32 days. So I think the reason this happened is that the mean length of stay is not the only thing that governs R naught. The variance is also important. So in this version, I just kind of randomized all of the length of stay distribution values and showed how it correlates with different length of stay statistics to R naught. So you can see here, if the mean length of stay is higher, R naught does tend to be higher, but there's a lot of scatter. Interestingly, the standard deviation of the length of stay has more of a linear relationship with R naught. We also tried the variance to mean ratio, but the best one is this one here, which is the length of stay mean plus the variance to mean ratio. That one sort of seems to be sort of a fundamental statistic of the length of stay distribution that governs R naught. And actually, in a very simple version of the model, which just has one susceptible and one colonized state and no recovery, it's an exact solution of the R naught, that it's directly proportional to this statistic, the mean of the length of stay plus the variance to mean ratio. And so that's another cool conclusion, I think, from our paper that you can play with by using the R package. So in summary, we can use the functions in facilityepimath to calculate R naught and a model equilibrium for healthcare facility models. We can pretty flexibly represent heterogeneous dynamic, susceptibility, and transmissibility, including intervention-induced states through surveillance, decolonization, etc. You could also use this model to represent something like antibiotic exposure. For Clostridium difficile, for example, patients can go, during a hospital stay, can go in and out of being exposed to antibiotics, which makes them more susceptible to having a C. diff infection. You can use this framework to model that kind of thing also. Um, and then the other highlighted feature is the length of stay distribution. We can represent realistic, complicated length of stay distributions, and the model behind the scenes will take care of that in the calculations. And it turns out that the details of those distributions matter in unexpected ways. Specifically for applying this model to CRE, a multi-drug resistant organism in long-term acute care hospitals, we showed that R naught bigger than 1 for a single stay is a realistic possibility. Mid-stay surveillance for carriers can reduce R naught less than 1. Decolonization also helps a lot and decreases the amount of surveillance you need to do. And that any efforts to sort of reduce length of stay should emphasize both the mean and the variance of the distribution, which I think is underappreciated. So thanks for listening. Any questions? Eric, I see a hand up.
Yeah, Damon. Thanks for this. It's really cool, and I'm probably going to end up using it at some point. So I'm happy you presented on it. I had two questions. One is, I know the underlying model is deterministic, but have you thought about doing anything that lets you present an uncertainty analysis or confidence intervals or things like that? And then the other question is, sort of thinking about extending this, how hard coded is that sort of baseline underlying model? And if you wanted to change that beyond changing the distributions of the variables, but wanted to change the actual model, how heavy a lift is that from a coding perspective?
Yeah, I think I'd like to use this package as kind of like a hub for adding more features. Um, the I think it would be relatively I think yeah it is among my ideas to add in like stochastic simulation piece. Um, I guess it would take some since most of this is analytic and sort of simulation free.
Yeah.
Um, that but I we've it's I have other pieces of code that do stochastic simulations using a similar framework, similar assumptions using like a Gillespie algorithm or something like that.
Mhm.
So adding in a simulation piece would be interesting. Getting a sort of analytic simulation result or analytic stochastic confidence intervals would require some more math work probably. But the simulation piece could do that. So that's among the things that I would like to add, which would be cool. As far as the framework, it's I guess the main thing that it can't represent is sort of like um, something like cohorting or like multiple wards where you have transmission only within a ward, where you have a sort of unequal exposure.
Yeah, that
So
was sort of my thought,
yeah,
but
one of the key things that makes the R naught formula work is the fact that this alpha applies to all the susceptible equations. I've done a little bit of analytic work on the cohorting problem, but just sort of early stages. But that is another direction that I think would be cool to go in. But actually, yeah, this R naught formula, um, which is pretty flexible. You can have any number of susceptible states, and the flexibility of the length of stay, I think, is more flexible than a lot of other formulations. But the fact that we can even get this formula part of the reason was that sort of equal exposure
Depends on that alpha playing
function.
nicely with everybody.
Yeah, if that doesn't play nicely, the R naught problem gets actually a lot harder,
Okay.
but not impossible,
Yeah.
maybe. Yeah.
So this is very cool. And I think if you ever find yourself modeling jails or detention centers, it would probably work for those too.
Yeah, yeah, I was thinking of pitching it more broadly because any sort of closed population that has a kind of admission discharge process like a open system, I think would also fit this framework. Um, so something like a jail or even like a workplace or something, I don't know, but yeah. But I think that admission discharge component is kind of key. Um, and allows the system to reach like an equilibrium because of the constant admission rate and stuff like that. But yeah.
I had a comment. Damon, I think this is really cool. I really like this. And it's related to what Eric was mentioning too. I was going to say during the COVID times, I saw a study after COVID that showed that the Paxlovid rebound, so when people would take Paxlovid and then afterwards they'd get another set of, reignited infection, it was thought to be due to a too short of a time that the person was treated. And
Mm.
so, what that made me think of in terms of what you just presented is that if the length of stay is decreased, then I think like this model could be used to answer some other really interesting questions too. So, like you could look at like that balance between if you reduce the length of stay so much that actually people aren't fully treated, and then they go back out into the community, and then they can start another epidemic there, and then come back to the facility. So it could be really interesting, with what you've started already to look at some of those questions. And I know they're also relevant for jails and prisons that are looking at things like MRSA. So when you have like a MRSA infection inside a jail, then they would say, oh, if we reduce the amount of time that the prisoners are inside and send them back out to the community, so that is better for the jail or the prison, right? But then they're just going back into the community, and then if they're not fully treated, then they're going to increase the epidemic out there. And then if there's recidivism and they come back, there's like these different cycles you can get. So I think this would be a really nice starting point to address some of those questions too.
Yeah, thanks. And I've started and I want to add more another direction of adding more pieces to this would be multi-location or multi-facility models. Like these LTAC patients, for example, their LTAC stay is hardly the beginning. These are like the sickest of sick people. A lot of the people in LTACs are actually transferred from an ICU of a short stay hospital. And then a large portion of them probably also live in nursing homes if you have a lot of elderly people. So someone getting discharged from the LTAC may be just being sent back to a nursing home, which is also a hotspot for transmission. So I think some of those dynamics um, that may have some nuanced effects. If you're trying to get someone quickly out of one place, you're just sending them back to another place where they could also be transmitting, right? Yeah, and that multi-facility framework might create even more examples of above threshold transmission, where something like C. diff, other studies that have tried to look at single stay are not almost never find something below one above one for a single hospital. But maybe in a network of hospitals and nursing homes, then there's sort of enough stay time where you get sort of a super critical like system of hospitals, even if one of them in particular is not amplifying by itself. Well,
Thanks.
I think of people going home and transmitting C. diff to their family members has also been documented. So relating this to household transmission is another thing you could add. But any other questions? I haven't one of my longer term ideas is pitching this um to see whether it's worth an effort of making this a little more user friendly, maybe with a Shiny app or like actually having more sort of tutorials about how to build in assumptions to someone who's not, a differential equation modeling expert to be able to use this might be a heavy lift. But there may be ways to sort of do that. But as of yet, we haven't found, hospital epi type people who might be directly interested in using this kind of tool to study what they're doing at their facilities, but it could be a possibility.
Yeah, I was actually going to ask you about that. If you have thought about how to make this tool kind of more readily available to evaluate studies or like have a quick look at, um, yeah, if someone is conducting an intervention or they're curious about what's the trajectory of an infection in their facilities, if they can use it without really having to know a lot about, yeah, modeling in general.
Yeah, I think it would be really interesting collaboration. And that there is a little bit of work out there. I know there's one paper that we cite a lot that sort of did a model of a CRE intervention and then actually sort of uh, tried to do an intervention and see how it compared to the model that they built of their specific facility. So I think there are maybe opportunities for doing stuff like that actually. Um, and it's interesting that CRE LTACs in Chicago that had the really bad CRE outbreak. They did an intervention, and we had a publication modeling what they did, not calculating R naught. But it's really hard to figure out what effect the intervention had because it's like bundled. Hospitals love to do bundled interventions where they do multiple things at once, right? Do more surveillance, put them under contact precautions, but then also try to improve, like hand hygiene practices, maybe do some kind of decontamination work of surfaces, decontaminate patient's skin using chlorhexidine glutamate. So they did all those things, and then they saw a decrease, but then you're left with the question, did they need to do all four of those things? Which component had the biggest effect? It's pretty hard to figure out. You got to make a lot of, well, if this worked this way, then this was the word on this one. There's a lot of sort of what if. Um, and I can understand why they do bundled because they want to make sure the intervention works. But there's some work to do in like using modeling to figure out, which piece had which effect. Um,
I
and
think
then, yeah, go ahead, Eric.
I think there is some potential with this package for sort of end users, not as the package itself, but as sort of a back end for a Shiny app that's more sort of intervention focused, like you said, like you don't need to be calculating R naught, but you can be like, if I try these interventions, what does this do to this number? Because we've been working on a platform to do that for hospital epi stuff where you can ask questions because whenever we present modeling work at like Shea, it's never like I have deep questions about the structure of your model. It's like I disagree with one of your parameter value choices because my hand hygiene rate's different. What does that do to your model? And we've been working on a platform to let people sort of play with those. It's essentially Python Shiny. But one of the issues we're running into is like stochastic simulation is really slow. And so while a clinician is sort of messing around with like, oh, but what if this happens? Like they're not really tolerant of like, yeah, you're gonna have to sit here for 15 minutes while we calculate that. So I think a fast analytical solution that's like, yep, you congratulations, R naught's below one now, is a potential thing where you're using this package sort of as the back end for something um that a model or an analyst has written, but is being presented as sort of a parameter choice type uh sort of dashboard.
Thanks. Yeah, Aaron, go ahead.
Yeah, Damon, this is super cool. And congrats on getting it up on Cran. That's awesome. Um, yeah, no, I really like the model and the way you've analyzed everything analytically. I just had a quick follow-up question to Eric's about getting confidence intervals for R naught, especially for your, more simple closed form examples. Is there a way for you to calculate the variance of your estimator since you have this nice distribution kind of in hand?
Could be. Yeah, I'd have to. The way to do that doesn't come immediately to my head, so it would take some thought. But
Okay.
um, yeah, I think. I mean, you have. I mean, yeah. The main thing that makes the R naught complicated to calculate is the sort of duration piece. Um,
Okay.
right? Because you have, at least in this version of the models, you have a pretty well-defined transmissibility of each colonized state. And then the complicated part is, how much time does each patient spend in each colonized state before getting discharged?
Mhm.
Um, and probably you could come up with something like a variance. So you could have like a R naught and then associated with the individual sort of variability, um, which depends on that C matrix of transitioning between the different colonized states and then the discharge rate. There probably is a way to come up with that there.
Yeah, it's like,
Yeah.
so all of that I would assume would increase your variance in your estimator. So you have like this kind of composite variance that would add up with somehow sum within this new distribution that you're building. Um, yeah, offhand, I mean, I can do it for a very simple, textbook problem. But once you have those integrals in there, that might cause some problems. But since
Yeah.
everything is closed form, it might be possible at least.
Yeah. And I think that another cool component of doing that would be to have a notion of transmission variability and like a super spreading. You
Yeah.
probability, even if R naught is less than one, you can have a very long stay patient, for example, who starts like as a personal R naught much bigger than one. Um,
Uh-huh.
so you could have these like outbreak flare-ups happening, even if the average R naught is less than one, which maybe is interesting to study. Well,
Then you could link your two different packages together,
yeah,
basically.
yeah, the branching process. Yeah.
Yeah, for sure. That would be awesome.